Swedish Neuroscience Institute to welcome you to Grand Rounds. And it's a wonderful monthly institution. Again, my name is Jens Chapman. I'm one of the spine surgeons here, and we're actually live, at least a small contingent of us. There's a large group that I see online. And today we have a really special, in every sense of the word, occasion to have a very cool speaker on a bittersweet, I'm going to say, occasion. Dr. Joe Dettori is here today. He is a Ph.D. and he has a unique perspective on spine. He's a statistician, epidemiologist of national and international renown, and he is, which is near and dear to my heart, a U.S. Army veteran and a Red Sox fan. So I just had to put that out there. So my conflict of interest is profound because I've co-authored several things with him, and I think the word sub-authored would be more apropos because he did the main brain work and I kind of got to trudge along. But Dr. Dettori is the co-founder and president of Spectrum Research, and his main partner, Dr. Dan Norvell, is here today. And he's done clinical research over 30 years. He has an MPH in health services and a PhD in epidemiology from the University of Washington. And again, in this function and capacity, he has been instrumental in running a large number of trials that starts with our government, with the U.S. Army's injury and epidemiology research activities in the Institute of Environmental Medicine. He has also been on several federal and statewide government agencies on official review boards. He's been on several IRB boards nationally and statewide. And he is, again, I don't know what the number of articles is, but published in the hundreds of articles and has co-authored several textbooks. He is a valued contributor to our Global Spine Journal in terms of having basic science reviews together with his partner, Dr. Dan Norvell. He has instituted new things like STAR reviews, where we have high-powered comprehensive reviews of the literature. And he's been always available for our fellows also as our representative of our methods core group to help them with their research. And we've had a very proud summary of research activities over the last decade, almost 8 years now, here at the Swedish Neuroscience Institute. His wisdom and his knowledge have been really very cool. He's always available to kind of help us understand how good the science is. And today we've asked him to not only reflect on his career, but also tell us a little bit more about what he, as an independent epidemiologist, thinks about this whole era of evidence-based medicine, which we're in, and give us an independent review of research in the world of spine, which is especially has been a lot of scrutiny, and just provides a frank review of his insights in this field, our accomplishments, our challenges and tribulations. So I thought nobody better than this on the occasion of his well-deserved but sad retirement. He looks better than ever. Dr. Joe Dettori, please come to the podium and give us your reflection.
Thank you.
Thank you.
Well, Jens gave me this opportunity, sort of one last presentation, if you will, as I ease into my retirement. And he suggested a theme broadly based on lessons learned in spine care research. And this actually gave me an opportunity to look back over my career and think about the individuals that I've had an opportunity to work with, the projects that I was involved with, and it actually was quite an enjoyable endeavor. So thank you, Jens, for allowing me to do this. Before I begin looking at some of the lessons learned over the last several years, I thought it appropriate to publicly acknowledge some individuals who've had a real significant impact on my spine research career. And I'd like to begin by identifying and mentioning this particular individual, Dr. Tom Kepsel. Dr. Kepsel was a professor of mine of epidemiology at the University of Washington. Several years ago, he retired in 2011, but Tom was an outstanding teacher. a great researcher and just a splendid mentor for many people, me being one of those. And of course, as such, he had a major impact on my thinking and approach. He was very clever in the way that he communicated solutions to complex and difficult problems. And he was just an unusual and is an unusually talented individual. For example, he had a deep interest in art history, and he completed a 6-year project from the years 2002 to 2007, spending 1 year studying Western art from each century, from the 15th century through the 20th century. And one of the spin-offs of the project that he was working on was a series of art cover commentaries for the Archives of Pediatrics and Adolescent Medicine. Now it's JAMA Pediatrics. And it's about different artworks and how they related to the lives of children. Here are some of the covers that are on some of those journals. And these commentaries are only about a half a page to a page long. Very, very interesting. I enjoyed going back and looking at those in preparation for this. Got sidetracked a bit, but very, very clever. So that's Dr. Tom Kepsel, would just like to mention him. The next individual, of course, is somebody you are all familiar with. Jens Chapman, we've started working together around 2005. And actually, it was my business partner, Dan, who first met Jens. Jens, I don't know if you remember when that was or where that was. It was on a bus ride from the airport up into Banff for one of the spine conferences. And so you and Dan got to talking, and you found out what our company did. And so that led to a very collegial relationship between our organization and you, and it was very helpful for us. And we've, as you mentioned earlier, have done many projects together. We've done 7 focus issues on a variety of topics, and we went on to start a journal, as you mentioned, EBSJ, and now folded into Global Spine Journal. And we co-authored together 4 books, our organization, Dan, me, and you, in these areas. So we just really appreciate the opportunity to work with you, Jens. We're thankful for your professionalism and just as thankful for your friendship. And here we are cultivating that friendship over a common interest that we have, and that is baseball. I don't know if you recognize all the locations. Of course, you'd recognize the Mariners, but
the Holy Temple. I want to point out on the right side, the gentleman in the sunglasses is Jeremy Fairbank. He's the godfather of something, of 3 letters that we use all the time, ODI, Oswestry Disability Index.
Yeah.
He's demonstrating his look-alike to Jeremy Clarkson, who's the British talk show host. And I think that's an empty beer glass. I'm pretty sure he would not drink water, but he's in good shape there today in that Fenway Park picture, demonstrating what do you think that ODI score on that day was for him? About 0?
Do you remember where this one is here, Jens?
Mariners.
The middle.
Oh no,
this
is Chicago. It's
Chicago White Sox. Yeah, very good. Okay. So anyway, I wanted to publicly acknowledge our relationship and thank you for your contribution in my life, Jens.
Thank you.
And then lastly, but certainly not least, I wanted to acknowledge my business partner and close friend, Dr. Dan Norvell. I first met Dan at Madigan Army Medical Center down at JBLM. We both were on active duty at the time, and it was in 1997. He was a young lieutenant when he first came, and he was soon promoted to captain. And we became fast friends with similar interests in a host of areas. And as you can see from this slide, Dan was quite an athlete. He is quite an athlete, a very good cyclist, a very good runner. In fact, he was a duathlete who competed nationally in that particular event. And that's important for what I'm going to say next about Dan as it relates to his time in the military. So this next slide is a picture of General Stanley McChrystal. He was a 4-star general when this picture was taken. You may or may not know this particular individual, but he was the commander of the Joint Special Operations Command, JSOC, from 2003 to 2008. And when we got to know him, he was a colonel, and he commanded the 75th Ranger Regiment at Fort Benning, Georgia. Now, there are 4 battalions that are underneath the regiment, and one of those battalions, the 2nd Ranger Battalion, is down in JBLM at Fort Lewis. And Dan and I were just finishing a study looking at the effects of different physical conditioning techniques on soldier injuries and their fitness and performance on a different unit, not a Ranger unit. And the Rangers heard about this. It got some publicity on Post, and they heard about this, and we were contacted by the Rangers because they wanted us to be involved with their unit. And specifically, they wanted us to analyze the nature of their injuries, try to examine their training, physical training methods, and to help develop strategies to reduce injuries and improve combat performance. And so we did that. And when I say we did that, actually Dan did that. I put him in charge of starting that program. But in order to do that, he had to be embedded with the battalion. He had to train with them. He even learned how to fast rope at that bottom right-hand corners, him jumping or roping out of a helicopter. Fortunately, he didn't fracture any ankles or anything, and so we're happy about that. But it was because of his physical ability, he could actually hang with the Rangers and received a lot of respect for that. And as a result of his work, a similar program was instituted in all the Ranger battalions. And I want to mention this because I know that the fellows will be working with Dan, have been working with Dan, will continue to work with Dan. And I just wanted to underscore the type of individual that Dr. Norvell is, very talented in many areas. So Dan, I just want to publicly thank you. I appreciate your friendship and your example as a husband, a father, and a man of integrity and faith. So thank you, Dan. Okay, well, let's move on then to lessons learned. The 3 that I want to emphasize today are those that are up on the slide. The first one that we're going to look at is one that affected me personally, and it's almost as if I had to mention it today as a way of confession. This particular one, I think, is quite insidious, more than we'd like to believe, and it affects all of us. And the example I'm going to use to underscore this is where I was the culprit in introducing bias into a study. So several years ago, non-operative low back pain was treated in the flexion mode. That is, it was believed that the lumbar lordosis was the cause of back pain, and that we had to reverse that through exercise and posturing and the way we lived our life. We needed to flatten the curve. That was the predominant thought at that time. Well, several years later, in the 70s and 80s, a competing view became popular, and it emphasized the opposite. That is, extending the spine and increasing the lordosis was the way that we were supposed to prevent and care for patients with low back pain that were non-operable. And this was promoted by a therapist by the name of Robin McKenzie, and he was from New Zealand. And he developed his ideas after he had a patient with sciatica come into his office for treatment, and he was busy, so he told the patient, if you wouldn't mind, please go into the other treatment room and lie down. And the patient misunderstood and ended up lying down in the prone position, hyperextending his back. And by the time that Mackenzie got to that patient, he was aghast, because that was anathema back then to do that, and asked the patient to sit up. And the patient declared that his sciatic pain was gone for the first time in weeks, and that his back pain had, even though it was still there, had diminished quite a bit. So he developed a whole system around this idea of extension, Mackenzie did, and he sort of gathered a bit of a cult following. And I have to admit that I joined that cult, if you will, and thought, yeah, that's probably the way to go, is extension. And I don't know if you know Jens, but Dr. Vert Mooney was a big advocate of extension. And so he was a professor in Dallas at the time. But whether extension or flexion is better for non-operative care, people with chronic or acute low back pain, this really was unanswered. And so we decided to do a randomized controlled trial to help answer this question in 1991. Now, the random allocation process consists of two steps. The first step is generating an unpredictable random sequence. The second step is implementing this sequence in a way that conceals the treatments until the patients have been formally put into the study. So for us, we generated a random sequence, and we allocated patients that met the inclusion-exclusion criteria using the system that I'm showing you here. That is, we had an Excel sheet that had patients 1 through 100, if you will, and we generated randomly through a computer what treatment each of these patients would receive. And so I give you an example of the first 8. But at the time, I was unaware of the concept of concealment. So what effect did that have? Well, the example I'm going to give you is that patient number 2 comes into a clinic, and I'm the one who's determining whether or not that patient's going to be part of the study based on inclusion-exclusion criteria. And this particular patient, let's say patient number 2, was going to be assigned to the flexion group. Now, I already told you that I had a bent towards extension. So my problem was I had access to this table. I knew that patient number 3 was going to be extension, and this was patient number 3. And when patient number 3 came in, I subconsciously or even consciously wondered, is this patient if he's going to be in the study, he's going to be assigned to the extension group, is he going to get better as quickly as patient number 2? I mean, he's unfit. I'm thinking, no, he's not. It's going to bias the results if I include him. If he's going to be included, it's going to bias the results against extension, because look at it. Well, it turns out that if you over scrutinize inclusion and exclusion criteria enough, you can exclude a patient. And that's what I did. I introduced bias by doing that very thing on patient number 3. So I learned a lesson. I didn't realize that there was such a thing as concealment, but concealment means that I would not know what treatment that patient was to get when I made a decision whether or not he should be put in the study. So biases occur in many flavors, and we tend to overlook them. We know they happen. We know that we have them, but we tend to minimize it in ourselves, rationalize it. We think other people have more bias than we do, but concealment is just one of them, and I use that as an example. The next lesson, the second lesson, has to do with systematic reviews. Now, we all know that systematic reviews are at the top of the evidence pyramid, but just because somebody does a systematic review doesn't mean that it's to be believed automatically. Not all systematic reviews are equal. And the example I want to give you has to do with spinal cord injury, and specifically the role of MPSS for the treatment of acute spinal cord injury. Now, there's a surgeon, a spine surgeon, Dr. John Hurlburt, who is not in favor of using MPSS in acute spinal cord injury. He did a systematic review. He's done a couple of systematic reviews on this topic. After his first systematic review, he was in a point-counterpoint article debating with Dr. Michael Thalines about this very issue. And I want to read with you on the slide his comments. He says, in summary, on this debate with Dr. Thalines, in summary, there should be no debate at all with respect to MP administration and SCI. Even though analyses, it should be though, not through, even though analyses of literature now span 30 years, the evidence for a therapeutic effect remains sporadic, inconsistent, of marginal magnitude, and the result of hundreds of retrospective comparisons, hence likely representing random chance alone. The heightened risk of complication, including infection and death, are very real and have been substantiated on numerous occasions. If, like Dr. Thalines, for some obscure reason, you continue to prescribe MP for the acute SCI, then you are not only risking your patient's health, you are risking their lives. And then he followed up in 2015 in a publication making a guideline statement that says administration of MP for the treatment of acute spinal cord injury is not recommended. So we were asked if we would look afresh at this topic, our organization, and so we decided to do that and to conduct an independent systematic review ourselves. Now, there happened to be 7 systematic reviews that were already published on this topic. And these systematic reviews looked at the efficacy and the safety. And you can see that with respect to efficacy, out of the 7, 5 said no, it wasn't efficacious, and 2 said yes if administered within 8 hours. With respect to safety, 4 said it was not safe. 1 said it was safe, and then there was 2 that, 1 was inconclusive and 1 that didn't address it. So we ended up evaluating these systematic reviews with a critical appraisal tool called the AMSTAR. The AMSTAR stands for Assessment of Multiple Systematic Reviews, and it is an 11-point critical appraisal tool, has 11 domains, if you will, that are felt to be important in order to have a high-quality systematic review. And you can see that the quality of these systematic reviews ranged from low quality with 2 out of 11 criteria being met, all the way up to high quality, 9 out of 11 being met. So, and everywhere in between. So we decided to go ahead and redo the systematic review, if you will, following the AMSTAR. So I'm only going to show you just a couple of slides with results because just to make the point that I want to make concerning what happens after we did the systematic review. So if you look at the motor scores, we found, if you look at this right here as the effect measure, and we found that there really was an improvement in motor scores in patients who received MPSS if it was done within 8 hours, but not if it was done after 8 hours. And as importantly, we looked at harms, and we found that there was no difference in terms of death, wound infection, GI hemorrhage, sepsis, PE, urinary tract infection, pneumonia, decubiti, and in the proportion of patients receiving one or more complications. So as a result of this, a new guideline was produced around the use of MPSS in acute spinal cord injury. And you can see that it's a little more nuanced than the one that was put out earlier by Herbert et al. And this allows the surgeon now some flexibility in terms of whether or not he or she wants to use MPSS within 8 hours of injury. So the second principle about systematic reviews not all being created equal, I think is important in a very practical sense, because as a consumer of clinical research, it's important for the clinician to understand how believable a result is. And just because somebody does a systematic review, especially in the spine literature, you can't just take those results and assume that they're accurate. And we published an article in 2020 where we looked at the quality of systematic reviews in 4 of the top spine journals, and we compared their quality using AmStar, and we published this paper in Global Spine Journal, and we found that we could have low confidence in the results of many of these systematic reviews, and it's unfortunate, but you just need to be aware of that. So I think it was a lesson worth repeating here today. This third lesson comes directly from another professor of epidemiology, Dr. Noel Weiss, who taught us that observational studies are often better than randomized controlled trials when you're looking at harms, especially harms that are rare. And so I think it's worth mentioning as a third lesson. Well, why is that? Well, because harms and adverse effects are often relatively rare, and randomized controlled trials are underpowered to detect changes in these rare events. And also, RCTs have relatively short follow-up periods. They're expensive to run. And so some harms can be missed due to a latency period. Some harms don't show up for a little while, sometimes after the RCT is done. So the example that I want to present to you concerning this lesson learned has to do with BMP and the risk of increased cancer with the use of BMP. So the timeline for this particular example begins back in 1965 when BMPs were first discovered. And then in 2002, Infuse was approved by the FDA for spine surgery, and industry began publishing articles about BMP2 use for spine fusion. And during that time, they were not reporting any adverse events. In 2006, we had some non-industry studies that started to report some of the complications that were associated with BMP use, particularly in the cervical spine. And then you can see that the FDA issued a safety warning in 2008. Well, in 2011, Dr. Eugene Karagi, who at the time I believe was the editor-in-chief of the Spine Journal, published a paper comparing the conclusions from the industry-sponsored trials of BMP2 to the data available from the FDA's summaries. And he concluded that these adverse events were not being reported accurately or transparently by the industry-sponsored studies. And in particular, he was concerned about the risk of cancer, which wasn't emphasized in the publications. And this is his paper that he published that began to create a stir in the community. So then he reanalyzed in 2013 the publicly available data from the FDA studies. No, I take that back. From the Amplify trial, Amplify having the higher dose of BMP, 40 milligrams. And he looked at that data and reanalyzed it. It was publicly available, that information. And he found and published the fact that there was an association between an increased risk of cancer and the BMP use in that study. And he published that in JBJS in 2013. At the same time, that same year, Medtronic granted $2.5 million to Yale University's Open Data Access Project, known as the YODA Project. And this idea was that industry could provide money to an independent organization, let the organization evaluate the claims independently and transparently, and they did that for their BMP2 product. Now, Yale University, the YODA project, decided to fund 2 centers to look at the data independent from each other, same data, just independently, and both decided to do systematic reviews around BMP use and the incidence of cancer. The first center was in the United Kingdom at York University. The second center is right down the street from us at OHSU, the Pacific Northwest Evidence Center. And so both of them looked at that. I'm going to show you 2 slides of the results. This is the one out of the United Kingdom. And you can see there's the effect measure here, the incidence of cancer, even though they found almost a 2-fold increase. The confidence interval was very wide because the events were rare. And so they said that the evidence of increased cancer incidence is inconclusive. They concluded that it was not conclusive. The OHSU Evidence Practice Center analyzed the data a little bit differently. They broke it up into 2 different follow-up periods because they had data on that. And they concluded that after 24 months, there was an increased risk, about 3.5-fold increased risk in cancer with the use of BMP. And they also found an increased risk at 48 months, but less so, and it wasn't statistically significant. So we decided, after looking at these data, that what was really needed to answer the question about BMP use in spine and cancer risk was that we needed to do an observational study that included more patients, and that this would help us answer the question. So that's exactly what we did. We designed a cohort study, and we knew that the state of Washington was particularly well positioned to help us answer that question because of the way that they keep some of their data. And so we wanted to look at all adults with lumbar fusion in the state of Washington between the years 2002 and 2010. And we identified them through the Comprehensive Hospital Abstract Reporting System, which captures almost all patients. Almost all hospitals have to report to this. And so we felt like we captured almost all the patients that received lumbar fusion during that time period in the state. And then we wanted to look at all reportable cancers except non-melanotic skin cancers. And we identified these people through the Washington State Cancer Registry. Now, the Washington State law says that if cancer has been diagnosed in the state of Washington, it has to be reported to this cancer registry. And so it turns out, as people have evaluated this registry, it's a robust registry that's been shown to be both valid and reliable. And then we finally connected these two databases so we could see which of these patients who had spine surgery ended up having a cancer diagnosis. So we ended up with over 4,000 spine fusion patients receiving BMP2 and over 12,000 fusions without BMP2. And again, just briefly, I'll show you just 2 slides on the results. I don't know if you can see it on the slide, but there are 2 curves here. They overlap so much that it's hard to distinguish them, but essentially, we found that there was no difference in a cancer diagnosis over time. The hazard ratio, after we adjusted for the fusion site, whether it was cervical or lumbar, was 0.92, the hazard ratio, so not significant. Furthermore, there was no difference in the risk based on the site of fusion, cervical or lumbar, or the type of fusion, anterior only, which tends to have a lower amount of BMP2, posterior only, higher amount, or whether it was combined. So we followed up our study a few years later to increase our follow-up time to a mean of 8 years. In fact, the range was from 5 to 14 years, and we found still no increased risk in cancer. During the time that we were doing our study, a few other individuals were doing observational studies on the Medicare population, and they found no difference in that particular cohort study. In a case control study of Medicare, no difference. And then the commercially available database of MarketScan produced 3 studies that were observational studies that concluded the same as we did, that there was no increased risk of cancer with the BMP2 use. And so in our study, we concluded that the following, that in an observational study, that we believe that it provided a more reassuring clinical picture in terms of the oncogenic device safety compared with the early positive results reported in the original RCTs, with their critical limitations of their likely incomplete ascertainment of cancer cases, their reliance on short mandated FDA follow-up periods, and the relatively smallish cohort sizes not suitable for rare case event evaluation. In other words, our conclusion stated just exactly what I told you about why observational studies can be better than randomized controlled trials in these situations. So today you allowed me to review 3 key lessons that I believe are worth recounting. The first one, to relieve my conscience, and the other 2, because I think, as I mentioned before, you being consumers of clinical research, this I hope will be helpful to you as you go forward in your career. I'm speaking particularly to the fellows now. And so I want to thank you for your attention. I appreciate it.
Thank you so much, Joe. This is terrific. And again, congratulations on such a rich and long and successful career. And you've been truly helpful to our community. Let me start with the first point, bias. So in your long career, and without having to go into specifics of organizations, how often have you encountered unbiased sponsors of studies, especially on a federal level? Isn't there always some, or isn't it common, I should rather phrase this more neutrally, isn't it common that sponsoring agencies or organizations that ask for a evidence-based review, that there is some bias introduced in how these key questions are phrased, how the questions are assembled?
Yeah, well, yeah, so of course, the short answer is, yeah, there's always going to be bias. And the goal of doing good clinical research is to not eliminate bias, because you can't do that. It's to minimize bias, right? And so, yeah, so bias comes in the form of who funds it, right? That's one form. That's why Yale University started the YODA project, so that they could be the intermediary. I don't think that eliminates it, that form of bias, which comes with money. Money changes everything, right? So yeah, so everything has bias. The goal is to minimize it and to try to identify it, right? And that's why sometimes it's the journals basically ask you to declare potential forms of bias, potential conflicts of interest, because even though there may not be any, the reader needs to know that it's potential. And so then they can make an evaluation, so.
So that's the first thing. So in our state, we've been frequently frustrated with our health technologies evaluation process, which claimed to be evidence-based, as biased clinicians in terms of how key questions were phrased. And although there was a commentary period, we felt that our attempts at trying to provide meaningful clinical input were frequently thwarted. So what is your suggestion to the spine surgery community, which is, of course, biased because we draw an income from our clinical activities, to respond to agencies, whether state or federally based, when there is a pretty clear bias present in terms of how health technology assessments are conducted? What's your advice to us as an outgoing, now retired, safe epidemiologist? How can we fight biased evidence gathering efforts?
Well, specifically as it relates to health technology assessments, I've been on both sides of that, being somebody who's been a part of doing the health technology assessments and in several of those. And I would say this to the spine community and to any clinical entity. When you approach in the state of Washington, unless it's changed, now I haven't been part of that for a few years, but my observation is that when you approach them, don't approach them with everything that we do is good and everything that these people are writing about is bad. Actually declare up front some of the weaknesses in the literature, in your own literature, okay? Declare that up front, and then come across as a reasonable individual in the sense that, yeah, I know that there's bias, but this is the best data we have, and show up to the meetings. I think one of the biggest effects, and when we did the health technology assessment on the artificial disc replacements, I don't know if you remember this, but you showed up with Dr. Devine, and he brought some soldiers and emphasizing the benefit of the cervical. And I think that had an effect on the committee as I watched the discussion. So that was good. But we've had several physicians who have come from the East Coast, sponsored by the big device companies, to stand up for their practice and the product, and completely, in my opinion, unreasonable. And so as soon as you come across as being unreasonable, then human nature, the committee is made up of members who want to do the right thing in general. And human nature has it, if you come across like that, they're going to be hyper defensive. So be open, admit that, yeah, all the studies, no studies are perfect. This is the best we have. This is our clinical experience. We want to work with you. Or not part of the structure that is just trying to resist. And that would be my recommendation to the spine community.
That's very helpful to know, and I fully agree with that approach. And yeah, it remains a source of frustration, but it's been more recently de-escalated for a variety of reasons. Let me explore a topic that just came up as you mentioned artificial discs, and that is cultural sensitivity. This has become a big issue in many different aspects, but how should we try to quantify or qualify studies that preeminently come from one cultural area or have distinctly different surroundings in their surgical practice in other cultures that are in our literature? I'll give you two examples. For instance, just pertaining to discs, and that's what triggered my memory. In the last lumbar disc discussion in the HTE assessment program, a single study from Norway was quoted where the surgeons are allowed to do just about what they want, and they had 1 or 2 deaths in there, but their surgical practices are completely different from ours, where we are only allowed to do 1, and we always use access surgeons. There they had no access surgeons, they could do 3 or 4 levels, and again, this is where some bad things apparently happened. So how can we, just to generalize this point, not to go into that specific, how can we assess the cultural surroundings as evidence is presented? The second example would be, for instance, myelopathy studies and laminoplasties. They're very heavily weighted towards the Asian cultures, and specifically Japan. Probably 80–90% of these publications come from there. How can we, in a far more culturally diverse environment like the US, apply insights of such studies where there are different regulatory, surgical practice, or cultural realities present?
Yeah, I mean, very good question. So it really comes down to the issue of generalizability. How can we generalize the results of a study that was done in a different culture, as you just mentioned, to ours? And specifically, how can we convey that information to a governing agency like the state of Washington, who's deciding whether or not to pay for it? And I don't know that there's an answer to that. I mean, the data that's published is the data that's published. And what needs to be done is we need to have studies done in our culture so that, we can undergird what we are doing here in our particular geography and our practice. But even that varies by region of the country for some things, right? So I think the whole issue of generalizability doesn't get enough emphasis, especially with respect to a governing body. On their side, they have to base their decision on some form of data. So I guess the answer is we need to do studies in our particular culture and try to educate the authorities that are making these financial decisions that the generalizability isn't necessarily what they think.
So would I find your agreement that when we review multiple, let's say, systematic reviews or studies that were done in our specific regulatory, medical, legal, and cultural environment should outweigh studies from other cultural circles where different standards apply? Is that fair to say?
Well, it's fair to say, given everything else being equal, right? I mean, that's one component about the weight of that particular study. There are other components. I mean, if you have a crummy US study and a really good European study, well, I mean, it makes it messier, right? So yeah, it's one component that I think should be taken into account. And if you look at good systematic reviews, like the ones that are published in EBSJ, when they list the study and summarize the study, they'll tell you what country that study was done in. So you can you can look and make that assessment.
I have a big picture question, and I know Rod has a question also, but we want to use your last moments of non-retirement or peri-retirement to gain as much information from you as possible. So big picture question. You've done many different scientific reviews in fields outside of spine. If you kind of globalize your assessment of the quality of studies that you see in this contentious field of spine relative to other areas like cardiac or oncology, where do we stand hierarchically? How good is the quality and how good are the efforts of research in spine compared to other specialties? Your very subjective perspective.
Okay, so in my mind, I would separate your question into sort of two bins of practices, okay? The surgical bin and the non-surgical bin. And it's just a lot easier to do clinical research when you aren't doing surgery, right? Because you can give placebos, you can do all kinds of things. But with surgery, it's different, right? It's different. And so just by default, you're not going to be able to limit the biases in surgery that you could in non-surgical care. And so, for example, you're not going to blind the surgeon to the treatment given because the surgeon's doing the treatment, right? Where if somebody who's not doing an operative procedure, you can blind them, they can give a pill out to somebody and not know what that is. And so, so just by default, I think surgical clinical research is going to be have more bias introduced just by the nature of the practice. And so, you know, how does spine surgery relate to other surgeries? I would say that similar to other orthopedic surgeries, my observation, not as good as cardiothoracic surgery literature.
That's sobering. Yeah, Rod.
Joe, it's been great working with you, and I really appreciate just like your philosophy and your perspective, and really looking at, you know, just sticking to the evidence, the data, and being kind of very scientific about it. I think a lot of times, especially in spine, you know, like you eloquently pointed out, there's so many biases, there's so many different ways to look at data, and just to try to do it in a systematic way so that you go, okay, this is the result. What does it mean? You know, how did they come up with this? You know, I think that's really important, especially I think nowadays, because there's so many, I mean, there's so many journals now, you know, everything's online, there's open access, you know, and again, from what I'm seeing is, you know, I think the quality of the work that's being put out is gone down a lot. You know, some of the reviews you read, like from, you know, other countries, and, you know, they have these editorial boards, and I think it's more important now than ever to stick to these research principles that you talk about. So, you know, we've been really fortunate to work with you. So,
well, thank you. I
really appreciate, you know, your perspective and your experience. I think it's been invaluable, especially for the fellows, because, you know, when you get out and practice, you know, we get bombarded, you know, from industry, companies, and they always get, oh, here's a paper we wrote, and you have to be able to critically analyze it.
Yeah.
I mean, so what if it's been published? That doesn't mean anything. In fact, I would be very skeptical of it.
Well, thank you. It's been great to work with you as well, Rod, and with the fellows. So I appreciate that. Thanks.
This is Dan Norvell, Joe's business partner, but more importantly, friend, and so appreciative of the influence you had in my life as a friend, as a mentor, and probably wouldn't be in research if it wasn't for you, asking me to challenge everything that we did. And so I appreciate the walk down memory lane, and typical of you, in a very humble way, acknowledging others, but giving those that have been involved in your career credit, but you've had a major influence on a whole host of people that if they were here today would acknowledge that. And I, for one, I need to say that. So I appreciate it. Look forward to our friendship moving forward. But I do have one question. It's non-scientific because we do science together all the time, so that can get boring. What are the plans for this 2 6-month vacation in the future? What is it that you're going to be doing?
So I thought, since I'm a Husky and Dr. Norvell is a Beaver, I thought the question was going to be, who's going to win the game this week? I don't know the answer to that one, but I do know the answer to the retirement question, and I plan on spending time with my grandkids. I have 6, all in the Seattle area. And just participating in some of the hobbies. I like to work out, so I've been doing that more frequently now. And I like to cook, so I'm gonna do some of that. And Lurley and I like to travel, and we plan on doing more and more of that as well.
So this is really a sentimental and sad moment. I want to just point out in this slide, this is a cool thing for me as I left academics after 25 years and went into the private world. On the left hand is our then executive director, Mr. Andy Cosentino, who was so visionary to form a formal contractual relationship with Spectrum, thus enabling us to have a really outstanding academic basis in terms of our methods, core capabilities that is enviable that we did not have in 25 years at UW. I need to say it very clearly. I have one parting medical question. Make it as short or reasonably long as you want to. And that is one of the essential questions that we always face in spine fusion discussions. We just had that yesterday morning, the nicotine question. In all your years of research and having read through hundreds of studies and reviews, is nicotine in the end bad for spine fusions, yes or no? And why do the Europeans and we have such divergent results?
Well, I don't know the answer to the second question. I'd have to sort of relook at that, but I think that, yes, I would say obviously tobacco use does have an effect on fusion rates. And I think, I'm trying to think back on a project that we did looking at that specific risk factor. So I'd say yes. I'm not sure why the Europeans and the American literature, I'd have to look that back up. And
so let me then rephrase the question a different thing. What do you think in our spine world is the single biggest challenge in terms of going forward? Is it overutilization of procedures, for instance? Is it too much kind of implementation of high tech without proof? Where do you see our biggest challenge? What would your advice be to especially our young fellows as they move forward? What should we focus on to kind of prove to the world, to our society, to our patients?
well, of course, the answer I'm going to give you is going to be slanted towards my profession. You need to prove what you're doing through good clinical research. You need to hire Dr. Dan Norvell to make sure that those studies are done correctly.
And along those lines, I pitched tomorrow morning, we have Journal Club. It's a broadcast through SSF TV. I want to thank them for coming in and for all of you for tuning in tomorrow morning at 6 a.m. The topic is going to be the sport trials revisited. And Dr. Norvell is actually going to pitch lead off to give us a big picture review on the major insights that were not anticipated on these studies, not the clinical ones, but what we learned in terms of what you mentioned, and that's PRCTs. And again, this might be the study that ends all PRCTs because the data was so weird and difficult to understand. And our fellows are going to present 3 major sections of this research. So tomorrow morning, 6 a.m., please dial in for this very important kind of a project review and update in terms of surgical practice of common conditions. So a little pitch. It's been a true pleasure. I hope this is not a goodbye, but a welcome and congratulations to your well-deserved retirement. We have a couple of little things. I know you're tieless here, so we would love for you, if I may open that box.
Yes, please.
We would love for you to not throw away all your ties, but if you keep one tie, make it this very tasteful blue, which would go quite nicely with your suit.
yes.
So I hope you have many ongoing occasions to proudly wear the SSF tie.
Thank you.
We also, first and foremost, would like to, here, I can take this box from you.
Can I put it together?
We would like to present you with a plaque. I know you may still have an office, so this is on behalf of all of us. And Rod, do you mind coming up and joining us here? Is a plaque to help commemorate your ongoing friendship, but longstanding work with this. So thank you for this work. Good, thank you. And finally, and we appropriately put this into a paper bag and not something else. We wanted, and you have to show the label to the audience because this represents what I think of you in a personal way. So this is a Prohibition era packaging, compliant. I pull this up. So this is what I think of you. You're a major buck in a field of dwarfs and mushrooms. You've been an outstanding contributor to our society. I hope you have many evenings where you can sip on a very successful career and fond reflection of your time with us.
Very nice. Thank you so much. I really do appreciate it, Jens. Thank you.
Thank you, Joe.
Great.
Thank you.
Great job.
Let's do one more. Can you take a picture of us?
Awesome.
Final question, who's going to win the World Series?
I'm afraid it's going to be Houston. I don't want that to be the case.
Okay, all right. Go Sox, right? Next year.
Yeah.
Thank you, Joe.
Thank you.
Thank you again.
Jens. We'll talk to you.